Assalamu alaikum and good evening, ladies and gentlemen. I'm Dr. Tayyaba Ali, and on behalf of Pakistan Association of Pathologists, I welcome you all to the 76th PAP Rawalpindi Islamabad local chapter meeting. So before starting the meeting formally, I would like to thank Dr. Manzoor Ijkazi, Chief Executive Officer, Shifa International Hospital, Dr. Imran, Colonel Nadra, and the management of Shifa International Hospital to be generous enough to host this 76th PAP meeting. So let's begin today's meeting with the recitation from the Holy Quran. And for that, I would like to invite Dr. Osama onto the stage for recitation.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم ألم تر كيف فعل ربك بأصحاب الفيل ألم يجعل كيدهم في تضليل وأرسل عليهم طيرا أبابيل ترميهم بحجارة من سجيل فجعلهم كعصف مأكول. Translation. In the name of Allah, the most merciful, the magnificent. Have you not seen the Lord who have turned against the people of the elephants? Did he not make the plants into misguidance? And he sent against them the birds in flocks, striking them with the stones of a hard clay, and he made them like eaten straw. Sadaqallahul Azim.
Thank you very much, Dr. Osama. Now I would like to invite Professor Dr. Lubna Naseem onto the stage for her opening remarks. Ma'am, please. Thank you.
Bismillahirrahmanirrahim. Assalamu alaikum and a very good evening. Indeed, it's a pleasure to see a lot of people we don't regularly get to see, and organization of such a meeting on a weekday, I'm sure, is not an easy task. But like Tayyaba has already thanked them, I also extend my thanks to the department who has managed it and the administration who have facilitated it. Before coming to the meeting, I was just reading up on what we have been doing in the past. So a news which caught my attention was that the Nobel Prizes for medicine and biology have recently been given to researchers who worked on autophagy and the biological circadian rhythms. The work by the Japanese researcher on autophagy sort of got my attention again because it is something we've been studying since third year, and yet it has been a topic which has sort of gained world recognition because it not only allows the scientists to research and read about what the human body is doing, but also how to undo or how to see what its results are. And the second thing that is interesting is that still we are looking at and awarding people who talk of the biological circadian rhythms. Although in our lifetimes we have seen youngsters sitting in front of a small screen all night and in the morning trying to make up for the same in the classes as well. So yes, it is science which is developing and it is growing and it has still got a lot of frontiers to cover. So, but in our field of pathology, I'm sure we all have our challenges and they take us to newer heights. Then again, what is being done in different areas is really commendable. The most important is that we still want to help humanity or help ourselves. We want to look for cures, we want to look for better diagnostics, and we want to look for the reversal of the aging process, which is again very interesting. We want looking for the eternal fountain of youth and immortality. So These things just came to my mind when I was, going through these news in the recent past. But one thing that has been, I'm sure, very, very well researched, well diagnosed here in this department is the malignancies, whether they are hematological or non-hematological. So this is one of those times where, again, as the president of the local chapter, I would want that there should be more collaborations. There should be food for thought that we should talk about tumor registries, and we should talk about centers of excellence. We have seen a lot of centers doing a good work, but this all is, again, unfortunately, fragmented, and there is no central registry for the tumors that are being diagnosed, and then we cannot, in the near coming future, we cannot make guidelines. So my one very important request to all of the present people who I see, my teachers from FIP, my training days, and people who have come up in their fields as the top of the line, they all must sit down and talk about that as well. So not wanting to keep you away from the actual scientific program, I would just like to mention here that we are on the eve of another very important academic activity in the field of pathology. Tomorrow we are starting the Society of Hematology. The Pakistan Society of Hematology is arranging a conference, which is a first 4-day workshop conference, and it is in Rawalpindi, and it's I'm sure one very important part of the academic calendar of all trainees. So whoever has not registered or who has not decided to go, you must go and see that hematology, how diversified it is now. And in the end, I would just like to mention that once you move on with your careers, there are people who you cannot forget. And at this time, I would like to mention Dr. Khalid Bukhari, who was one of those very, very humble people, the best of teachers, the most committed of workers. He passed away recently, so please recite Fatiha for him and remember him in your prayers. And not wanting to keep you too much away from your activity, I hand over the stage to the academic session. Thank you very much.
Thank you very much, Professor Dr. Lubna Naseem. As we all know that the PAP meeting comprises of 2 parts, the first academic session, followed by the business session. So we have very interesting presentations for the academic session, and for the academic session, I would like to call upon Dr. Zafar onto the stage. Over to Dr. Zafar.
Bismillahirrahmanirrahim. Good evening, everyone. We have 3 talks for the academic session. The first one is from Dr. Shivana. She is section head cytogenetic lab. She is a graduate of Army Medical College, and she got her training from AFIP. So Dr. Shivana.
Bismillahirrahmanirrahim. Honorable guests, my seniors and colleagues, Assalamu alaikum. I'm Dr. Shavana Kamran, Assistant Consultant Hematologist, and recently I have joined Shifa Tamir Millat University as an Assistant Professor of Pathology, and after receiving a specialized training in cytogenetics at University of Chicago Cancer Research Center, I was able to establish the lab with the guidance of Dr. Imran. Thank you, sir. Before I start, I will tell you the scheme of the presentation, that is the introduction of cytogenetic testing, and then I will share the data of the cytogenetic studies at Shifa International Hospital, and then I will share the interesting cases. Now, cytogenetics, as we all know, is the branch of genetics which is concerned with the study of chromosome structure, pathology, and function. There are two basic categories of cytogenetics, that is conventional cytogenetics, in which the chromosomes are studied on gym-trypsin binding chromosome. Then comes the molecular cytogenetics, which has two categories, fluorescence in situ hybridization FISH and CMA, but I will not go into the detail of FISH and CMA. Now, first of all, the purpose and utilization of cytogenetic testing, it deals with three basic groups. That is the neonatal pediatric group, gyne-obs patients, and heme oncology. In neonatal and pediatric patients, patients are usually referred to study the autosomal aneuploidies, and the most common aneuploidies is trisomy 21, that is Down syndrome, Edwards syndrome, and Patau syndrome. They're also referred for sex determination in cases of ambiguous genitalia, and sex chromosome abnormalities commonly diagnosed Klinefelter and Turner syndrome, and then the patients with mental retardation and family history. In gyne-obs cases, couples with recurrent abortions, infertility, primary and secondary amenorrhea, and prenatal diagnosis are usually referred for cytogenetic testing. Cytogenetic testing is the backbone of heme oncology cases, as it helps in the diagnosis, prognosis, disease monitoring, and bone marrow engraftment monitoring in sex mismatch bone marrow transplantation. The prerequisites for cytogenetic testing is most important clinical history, including the family history of the referred patient. Positive physical examination findings also help in the diagnosis, and appropriate specimen is most important because viable dividing cells are needed. The transit time should be less than 24 hours, and it should be transported at room temperature, and sodium heparin, ideally without preservative, are recommended. In heme oncology cases, along with clinical information, morphological findings on the peripheral blood, bone marrow biopsy, and tissue biopsy are important. Flow cytometric analysis along with immunohistochemistry if available, and again the appropriate specimens. Now the specimens that we can use for cytogenetic study includes, in non-hematological cases, we can use peripheral blood and skin fibroblast for the constitutional abnormalities, amniotic fluid, chorionic villus samples for the prenatal diagnosis. Products of conception and umbilical cord blood is used in special circumstances. In heme oncology cases, usually for the hematological malignancies, peripheral blood, bone marrow, and bone core biopsy in case of difficult aspirates can be used for chromosomal analysis. Lymph nodes, tumor masses, and body fluids can also be used. Now, as far as the procedure is concerned, first step is culture initiation. Culture initiation, timing of the culture depends on case to case, and it is usually subjected in a culture medium, and it depends on the case whether to use mitogen or not. After that, we subject it to the harvesting phase, which consists of metaphase arrest using mitotic inhibitors, hypertonic swelling, and fixative. Then comes the slide making using the gym-trypsin banding, and then software-assisted metaphase analysis. Tests available at Shifa Cytogenetic Lab are peripheral blood for karyotyping for the constitutional abnormalities, cytogenetic studies of heme oncology cases done mostly on the peripheral blood. If blasts are there, we can use the bone marrow, bone core, Fanconi anemia screening for chromosomal breakage analysis test, donor chimerism studies, XX, XY chimerism of sex mismatch bone marrow transplant patients. We are also doing the fluorescence in situ hybridization, that is FISH. Dual color, dual fusion probe are used, BCR-ABL and PML-RARA. We are also doing HER2-neu amplification probe in breast cancer cases. In near future, we are also planning to use 1p36, 19p13 for gliomas, and MLL gene rearrangement for high-risk acute lymphoblastic leukemia, and XX-XY chimerism in sex mismatch bone marrow transplant by FISH. Now, I will share the cytogenetic lab statistics Total workload from January 2016 to January 2018. In January 2016, we did 309 cases, and there are rate increases in 2017 for a total of 478 cases. Now, these are the frequency distribution of different categories. First, I'll share the neonatal and pediatric cases. We did 201 samples, out of which Down syndrome was the most common finding, followed by the Klinefelter and Turner syndrome, and the patients who were referred with ambiguous genitalia had an abnormal karyotypes. In gyne-obs cases, we did 196 cases, out of which the most common was translocation, which consists of balanced translocation, unbalanced translocations, and Robertsonian translocations, followed by deletions. Marker chromosome was identified in 3 cases and inversions in 2 cases. We did 78 cases of acute myeloid leukemia, and surprisingly, we had complex karyotype in 10 cases. Translocation 1517 was identified in 10 cases, and marker chromosome was identified in 2 cases. Trisomy, we had 5 cases of trisomy, with trisomy 8 and trisomy 11 being common. In acute lymphoblastic leukemia cases, we had 4 cases of Philadelphia chromosome, which is a high-risk ALL, and we have identified 4 cases of translocation 11q23 involving MLL gene rearrangement. We did 26 cases for Fanconi anemia screening, in which 3 cases were positive. One of the most important achievement which we have recently achieved, JCI accreditation, and we are also doing the external quality assurance proficiency testing with College of American Pathologists successfully. And the overall cytogenetic lab culture failure rate is less than 5%. Now coming to the interesting cases which we have diagnosed in our lab. Case 1 is a full-term newborn with multiple dysmorphic features, hydrocephalus with agenesis of corpus callosum, enlarged kidneys with bilateral hydronephroureter, skeletal and joint abnormalities. The chromosome analysis done on peripheral blood showed trisomy 8 mosaicism. Now, this trisomy 8 mosaicism is a rare abnormality. Complete trisomy 8 severely affects the developing fetus and can be a cause of miscarriage, whereas the trisomy 8 mosaicism, these individuals are more likely to survive into childhood and adulthood, but they exhibit a characteristic and recognizable pattern of developmental abnormalities. My next case is 16-year-old female who has presented with the primary amenorrhea, ambiguous genitalia with aggressive behavior. Now, when peripheral blood karyotyping was done, we had the karyotype 47XYY, that is an extra Y chromosome. This finding was consistent with Jacob's syndrome. So it's a rare chromosomal abnormality, and it occurs spontaneously with a low risk of recurrence. Case 3 was a 4-year-old female referred from PEDS clinic. On examination, she was a short-heighted petite child, and peripheral blood karyotyping showed mosaicism for the Turner syndrome. We had 2 cell lines having 45X and 47XXX karyotype. Mosaic Turner syndrome, only few cases are reported with a variable phenotype, mildly affected females, and the phenotypes are less severe than 45X. Case 4 is 33 years old male, and he was referred for the workup of primary infertility. We did the peripheral blood for karyotyping, which showed 46XY, 86, 87XXYY mosaicism, with a half cell line having hyperdiploidy. The infertile male and female can have increased chance of having chromosomal abnormality, and one of the most common reasons why in vitro fertilization is unsuccessful and why miscarriages occur. And these abnormalities are usually transmitted to the embryo. That is why embryo is not viable. We had a couple with recurrent abortions. Wife was 31 years and she had a normal female karyotype, while the husband was 31 years and his peripheral blood analysis showed inversion of chromosome number 9 with translocation 911. Now this inversion 9, it is reported in the literature. Some researchers say that this is a normal variant, but there are a lot of studies that support that it can be associated with infertility, recurrent abortions. It can be associated with the male infertility. It can have abnormalities of the spermatogenesis, that is immotile or ultrastructure sperm detected, and it can be associated with the recurrent spontaneous first trimester abortions. Now my next case is, now I'm coming towards the heme oncology cases. This is an 8-year-old female child. Her bone marrow biopsy showed acute myeloid leukemia with a hypergranular blast. Her flow cytometry showed CD13, 33, and 117 positivity with the strong positivity for myeloperoxidase, low expression of 34 and negative for HLA-DR. Now this case was referred to us to look for translocation 1517 for the suspicion of acute promyelocytic leukemia. So when we did before I go into the cytogenetic detail, I'll show you the bone marrow aspirate, that medium to large size blast with immature chromatin and abundant hypergranular cytoplasm, having cytoplasmic vacuolations, prominent nucleoli and rods were seen, but we didn't have any abnormal promyelocytes. So the bone marrow cytogenetics showed translocation 821 with trisomy 4. Now, it is believed that translocation 821 is associated with a good prognosis, but it is a rare additional abnormality, that is trisomy 4. Trisomy 4 is basically when there is an abnormality in the chromosome number 4. So long arm of chromosome number 4 carries c-KIT gene. So when this translocation 821 is associated with trisomy 4, it has rearrangement in the c-KIT gene, which is associated with a worse prognosis in adult group of patients and intermediate risk in children. So this is the literature review which supports the idea that c-KIT abnormality gene is can be a risk factor for these patients. My next patient is 56-year-old male. Bone marrow biopsy showed acute myeloid leukemia with myelodysplasia-related changes. So this is the bone marrow biopsy, which is showing a blast with striking dysplasia in the megakaryocytes seen on the aspirate and the trifine biopsy. So when we did the cytogenetic testing, it showed inversion 3. This is the inversion 3 with monosomy 7. So AML with inversion 3 is a separate entity and it has a poor prognosis. But when it is present with monosomy 7, it is even have a worse prognosis. Case number 8 is an 8-year-old male child with the diagnosis of Burkitt lymphoma on the nasopharyngeal mass. Bone marrow biopsy showed infiltration by the Burkitt's lymphoma, and the bone marrow for karyotyping showed this translocation 814, which is associated with IGH-MYC hybrid gene. This finding is present in 70% cases of Burkitt's lymphoma. In addition, we noticed this duplication of long arm of chromosome number 1. This can be present as an additional finding in 30% cases of Burkitt's lymphoma. Now, case 9 is a 31-year-old female presented with a progressive pallor weakness. Bone marrow biopsy showed non-Hodgkin's B-cell lymphoma. Now, we have very interesting finding in this patient. We had this translocation 822 along with translocation 1114, and addition of an unknown material on the short arm of chromosome number 9. So this is a very interesting finding because translocation 1114 is associated with IgH, CC, and D1 hybrid gene, which is a hallmark of mantle cell lymphoma. But when it is present with this translocation 822, this is a variant translocation of 814 usually present in the Burkitt's lymphoma. So it carries, it results in the formation of IgH-MYC variant gene. So this is aggressive variant of mantle cell lymphoma, which is also known as double hit lymphoma, which is associated with the concomitant gene rearrangement of CC and D1 and MYC gene, and it is accounted for 5% of all mantle cell lymphoma cases. So it's a high-risk case. Case number 10 is 12-year-old female child who is a diagnosed case of beta thalassemia major. On day 30th, post-sex mismatch allogeneic bone marrow transplant, donor chimerism was done based on XXXY. So we had 100% 46XX recipient cell, and we suggested that this is a graft failure. We confirmed this finding by doing the PCR. So this is our cytogenetic finding. And this is the donor chimerism status by the courtesy of Genetics Resource Lab headed by Dr. Sir Sohaib. So this showed less than 10% donor chimerism. It confirmed our finding. So I conclude by saying that conventional cytogenetic has the ability to view the entire gene of an individual in a single test. It has a paramount importance in the diagnosis and clinical management, and the advancements in the tools and techniques has provided higher accuracy, resolution, reproducibility, low turnaround times, and cost. In the end, I would like to acknowledge Dr. Imran Nazir Ahmed, our worthy lab director, who has supported me, the whole pathology team, and my family for the support. Thank you.
Our next speaker is Dr. Mohammad Usman. He is section head microbiology. He, like Dr. Shuana, is also a graduate of Army Medical College, and he did his FCPS training from AFIP. Dr. Usman.
Assalamu alaikum. Honorable Chairman, Dr. Habib, respected seniors, and dear colleagues, Assalamu alaikum. My topic is antimicrobial resistance. So here is a blood culture report. It has a gram-negative organism, and in this report you cannot see any drug which is available here, and it is susceptible. So it is all drugs, they are resistant. Colistin, it is also intermediate resistant, and tigacycline, this is also resistant. So this is a monster of our own making. So conditions like neutropenic fever, liver transplant, and surgical site infections complicated by extremely drug-resistant organisms have adverse outcomes despite using last resort antibiotics. These are colistin, tigacycline, and fosfomycin. Antimicrobial resistance, this is ability of the microbes to grow in presence of a chemical that is antibiotic. Previously they were susceptible to this antibiotic, and they are no longer susceptible. And this resistance, this is occurring everywhere, it is worldwide, and it is compromising our ability to treat infections. So regarding AMR, it is compromising our ability to treat common infections like urinary tract infections, bloodstream infections, pneumonias, because of drug resistance, which is in all regions of the world. And this leads to treatment failure and worse outcomes. And moreover, it adds to the cost of treatment. It's about more than 30% adds to the cost of treatment. So World Health Organization, they gathered statistics in 2014, and this was from 114 countries, and resistance of significance was reported from every country, because every country is using antibiotics. So we are now heading towards post-antibiotic era, where antibiotics would no longer be effective. So in this report, two key antibiotics, carbapenems, they are no longer effective in conditions like pneumonia, bloodstream infections, and urinary tract infections, and neonatal infections. And ceftriaxone resistance in gonorrhea. So it is also very significant. It is more than 50% in some setups. So the figures of antibiotic use, they are horrific. So millions of tons of antibiotics have been used in last 60 years. This is from European Union report. The statistics show that 30 to 50% of hospitalized patients, they receive antibiotics. And almost half of these are unnecessary. More than 30% of surgical prophylaxis, it is not appropriate, and this contributes to the cost. So this is road to pan resistance. So first penicillinase, then cephalosporinases, including ESBL, AMP-C, and then carbapenemases, and now we have this new novel antibiotic, avibactam, so it is only available in the United States. So antimicrobial resistance, it's no longer a scientific problem, it's a political issue. So in 2016, the matter was taken with with the United Nations General Assembly, and so there was a global action plan for containment of antimicrobial resistance was in place, and subsequently all countries now have their national action plans. So what is the impact of antimicrobial resistance? And they have calculated that by year 2050, the impact will be enormous. 10 million deaths annually, and a reduction in GDP, and more than $100 trillion of expense. And the impact will be greatest in Africa, followed by Asian countries. Why antimicrobial resistance? So what are the reasons for this? Because this is due to selective pressure due to inappropriate use of antimicrobials, then weak regulations in healthcare, especially in developing countries like ours, and use of antimicrobials in veterinary medicine and as growth enhancers in poultry and other settings. So what happens when we give antibiotics? So when we give antibiotics, we have a good flora. We have a good flora organisms. So when we give antibiotics, we knock it out. And it is replaced by resistant organisms or mutant organisms. So it is selected, and that is how it increases. So what needs to be done to control this problem? First of all, awareness, training, education, then surveillance. This is mostly lab-based, so because lab detects the resistance. Then this is very important, infection control, then antibiotic stewardship, and research in new antibiotics and new diagnostics. So World Health Organization is promoting this concept of One Health and integrated disease surveillance. So One Health is because human, animals, and environment, they are related and they have linkages. So because antibiotics are used in humans, they are used in animals. So from humans it goes to environment, and from humans to animals, and vice versa. So this is a concept of One Health, that it is now multi-sectoral. So as we all know that prescribing antibiotics is a reflex action. So how all this developed? Because this is called AMR cycle. So it is a vicious cycle. So when we give antibiotics, so there is increase in this. It is resistant to one organism, then it becomes resistant to, it becomes resistant to one antibiotic, then to second antibiotic, then to third antibiotic. So antibiotic use causes resistance and maintains resistance. And cross-infection, it spreads resistance. So to reverse or to slow down this process, we have to reduce antibiotic use and to improve to improve infection control. So what microbiology can do in this, using correct methodologies for identification and susceptibility testing. For example, in some situations you need to do minimal inhibitory concentrations or MICs, then selective reporting of antimicrobials. Not all antibiotics tested need to be reported. And reporting significant results to the clinicians or the clinical staff and doing the clinical correlation. Then generating antibiogram. Every hospital must have antibiogram that I will show you. Surveillance and reporting for infection control. Then outbreak investigation. So if there is outbreak of multi-drug resistant organism, you have to find out the source. So unless you remove that source, you are not going to control that outbreak. And lastly, awareness regarding interpretation of laboratory reports, contamination, colonization, intrinsic resistance. So these are all important because you don't treat contamination or colonization. So the major threats in this country, in our country, that we have are pan-resistant Klebsiella, then carbapenem-resistant Enterobacteriaceae. This is extremely drug-resistant Salmonella typhi. This is ESBL type, which is resistant to third-generation cephalosporins. Then VRE, Acinetobacter, tuberculosis. This list does not include resistance in malaria and HIV. So you have to interpret the reports correctly, because this is a tracheal culture with occasional WBC, and there is light growth of Acinetobacter. So this is a colonization. So it does not need treatment. So you have to keep in mind intrinsic resistance. So these are given in comments that they are intrinsically, this organism, Stenotrophomonas, it is intrinsically resistant to aminoglycosides and carbapenems, so they would not be effective. Some organisms, they develop resistance during treatment, especially we have this Serratia, and it may develop resistance during prolonged therapy with third-generation cephalosporins. So you have to keep in mind that if there is a treatment failure, you need a repeat culture for that. So this is an antibiogram. Antibiogram is a cumulative data of drug susceptibility of organisms. So it helps in selecting empirical antibiotics for infections, and secondly, it helps in monitoring the trends of resistance. So this is another term that is very important, that is diagnostic stewardship. That is using correct tests for a particular infection in a timely manner. Like you have to use markers like WBC count, C-reactive protein, or procalcitonin for monitoring infections, sending appropriate cultures for diagnosis and serology and PCR. So keep in mind that typhi is no longer recommended for typhoid. Then pleural fluid, a lot of clinicians they send pleural fluid for TB culture and PCR. Please keep in mind that it is not a very good specimen for tuberculosis. So it has a very low yield for tuberculosis. So you can then send bone marrow cultures or CSF if you are suspecting fastidious organism in blood culture bottles. Then for acute brucellosis, this is the best test, microagglutination test. For chronic brucellosis, you have IgG, ELISA. This KOH, potassium hydroxide preparation, is sometimes very useful for early diagnosis of fungal infections. So ideally, the cultures, they should be sent before starting antimicrobials. Now, the specimen quality, this is very important because a low quality specimen can lead to confusing results. For example, for blood culture, you have to send 15 to 20 ml in aerobic and anaerobic bottle. Some specimens, they are very unsuitable type, like Foley's catheter, endotracheal tips, then urine bag specimen, then saliva instead of sputum, then specimen in formalin or alcohol, they are also not suitable. The best specimen is tissue, if there is an infection of the tissue. This is followed by which is less suitable is pus, and this swab is least suitable, especially if you take superficial swabs. So they don't have a very good yield. So the conclusion is that AMR is a global problem, and we all need to work together to control it so that our future generations, they can have a better future. Thank you very much.
Our last speaker for the academic session is Dr. Ghazanfar Abbas. He is section head chemical pathology. He is a graduate of Jinnah Medical and Dental College. He did his residency from Ziauddin Medical University. Dr. Ghazanfar.
Bismillahirrahmanirrahim. They always say time changes things, but you actually have to change them yourself. A lesson I learned while implementing point-of-care testing system. Ladies and gentlemen, I am Dr. Ghazanfar Abbas, and today I will share with you my practical experience of POCT system implementation in this hospital. Now, what is POCT? The point-of-care testing is defined as a system of medical diagnostic testing performed outside the clinical laboratory in close proximity to where the patient is receiving care. Advantages: fastest turnaround time, quick, life-saving clinical decisions, a requirement in all critical care units of the hospital, demand, in fact, the dream of all clinicians, surgeons, and anesthetists. Now, what's the catch in POCT? POCT is typically performed by non-laboratory personnel, and the results are used for making clinical decisions. Now, these results should be accurate and valid for making such decisions, which could be life-saving. Now, coming back to the definition, the point-of-care testing is defined as a system. It's not only a device. Well, it has come to my observation that there is a general concept among the clinicians that POCT is actually a device. My brother, who is a nephrologist, also asked me to get him one of these so he can get the morning labs during his round. But when I told him about the system of POCT that I am about to tell you, he was convinced that this is not his domain. The role of laboratory in POCT is, as per College of American Pathologists, Joint Commission, and other accrediting bodies, it is a mandatory requirement that POCT system should be under strict monitoring of clinical laboratory. So it means that the clinical laboratory is now responsible for the results of tests which are not performed by the lab itself. Now, quality control of these devices, all of them, validation of results, training of operators, resolving all other major issues comes under the umbrella of clinical lab. However, daily maintenance, cleanliness of instrument, and minor daily issues are to be handled by the operator. Also, CAP and Joint Commission says that quality control, both internal and external, are to be run by the operators and not the lab personnel. So, adding more responsibility to the lab. It was a challenge. The biggest challenge was introducing a new culture. Actually, introducing a new culture is easier than changing the previous one. That's the nurses looked at me in my first meeting when I told them that I am about to change their way of glucose testing. Now, the drawback of device-only culture, using uncontrolled or self-controlled devices. The uncontrolled means the quality control material has not been run on the device. The self-controlled devices, well, one fine morning, a staff nurse called me and said, "Doctor, your lab glucose results are incorrect." I said, "Okay." I asked him how he came to this conclusion, and he said, "It's not matching with my glucometer result." Then I asked, "How do you know that your meter is working fine?" He said the meter is fine because he tested his own glucose and it was okay. So that's actually a self-control device. Using different devices in different shifts, causing a lot of inter-device variations. Also, you cannot have a look on the systemic errors. No confidence on results, causing many unnecessary lab confirmations. Many identification errors of both the operators and the patients. You don't know who operated the instrument and you don't know whose patient result is in the file. Now the challenges. The biggest challenge was to maintain the fastest turnaround time. Harmonization of results, to remove the inter-device variations. Selection of a centralized POCT system having devices with professional features. Training and certification of POCT device operators who definitely are non-lab personnel. Competencies of operators with records. Recertification of these operators. Running quality control material on all devices. Only allow using devices if the quality control results are all right. Validating those controls and keep an eye on systemic errors. All these tests performed on device should be made a part of medical record. All the tests should be charged to the patient on whom the test is performed. Fulfilling the requirements of accrediting bodies. These were some of the main challenges that I faced during the implementation of this system. Now the selection of a POCT system device. A good robust system with professional features like acceptable method for performing analytes, scanning the operator and patient ID, so there should be a no keypad because they will make a typographic error. Again, there can be an identification error. Operator and admin restricted functions. QC lock, a very helpful feature. In the previous challenge, I mentioned that there should be no test running without quality control. So this feature helps me as all the devices are configured to go on a QC lock at a periodic time, and they have to run the QC material, otherwise the devices will not operate. It should have the ability to identify whether patients or operators are authorized for the test, ability to transmit control and patient data with both Wi-Fi and LAN network. Both external and internal QC programs should be available for the selected device. All the devices should be able to control centrally through a centralized software. Now, what the flow of the point-of-care testing system? Whenever the patient is admitted, the medical information system transfers the info to the server and opens an account. Similarly, the data of POCT operators is also on the server, and whenever a new POC operator is assigned, its data is also uploaded. So this is a simple flow. The operator ID is scanned, the patient wristband is scanned, the sample is collected, the test is performed, result goes to the POCT server, validated, goes to the MIS, the verified report is available in the MIS, and the whole flow takes as low as less than 15 seconds. So this was the fastest turnaround time I was talking about with the identifications. We have so far installed 55 professional glucometers, 6 ABG analyzers, 5 coagulation check analyzers. The installation of these are under process. Also, there are 3 urine dipstick analyzers also available, also installed. We were successful in implementing state-of-the-art paperless POCT system throughout the hospital in a record time of less than 3 months. 55 glucometers were installed floor by floor. The ABG analyzers were installed on the OR, the ER. The training was given to all the operators, and the IT points, installations, the Wi-Fi, the networks, all the installation points were done in less than 3 months. So far, we have trained 1,158 operators and maintained complete training, competency record, and their performance record. This is required by the accrediting bodies that the operator assigned should be trained, their competency record should be maintained, and as I mentioned earlier, there has to be a recertification which is done on the basis of performance of the operator throughout the year, and you can set the laws that how many controls he has run or how many patients has he been assigned. So on the basis of that, you can recertify that operator. There is a significant increase in confidence on POC result, eliminating unnecessary lab confirmations. Accurate and valid results for making quick clinical decisions are now available, and alhamdulillah, we passed the Joint Commission thorough audit on the POC system. I would like to acknowledge all the effort done by my lab team, my POC coordinator, the lab administration, the maintenance department, the IT department, the networking department, all of them who helped me. Thank you very much, and thank you very much for listening.
If there are any questions from the 3 speakers, the forum is open. So before we head to the business session, I will request General Suhaib to, sir.
Sir, the Typhi-Dot, sir, it's based on the testing of serum, and it's based on testing the antibodies. And various studies, they have shown that it's not specific, and it has low specificity and sensitivity. This results in misuse of antibiotics. Sometimes when it is required, it is not given. Sometimes it is when it is not required, it is given. May I request Dr. Ijaz Khan, because being the clinician who is infectious diseases, practicing infectious disease. Sir.
What is the alternative?
Sir, the best investigation is blood culture.
Anything else?
Sir, blood culture, the gold standard is bone marrow culture. Then Vidal test is suitable, it is useful in some settings, but you have to.
Usman, I'd like to add on. I did the first 500 tests of typhoid that were done in this country, and working at AFIP under General Karamat. It happened to be my dissertation topic. So the original kit that we were using was from Malaysian research department, and it was an enzyme immunoassay. Fairly good against the 50 kilodalton outer membrane protein of Salmonella typhi. It did have some cross reactions with other Salmonella, especially Paratyphi, but good enough, and few Enterobacteriaceae as well. It was slightly subjective that you had to train your eyes onto that. But by the time it got replaced, by what we have now in terms of ICT, it is unfortunately positive in every fever except typhoid.
Sir, Dr. Jaz, please.
Thank you for giving me an opportunity. Actually, the typhoid, अगर आपने diagnose करना है तो clinical diagnosis is number one है. मेरे ख्याल में पाकिस्तान में अगर करना है आपने किसी गांव में किसी शहर में जहाँ पे आपको कल्चर ब्लड कल्चर नहीं कर सकते, वो इज़ एक्सपेंसिव थिंग. सो क्लिनिकल डायग्नोसिस फर्स्ट होगा. और अगर आपने कोई टेस्ट टाइफाइड से बेहतर करना है तो मैं कहता हूँ वाइट काउंट कर लें, WBC. इट इज़ अ पुअर मैन्स ब्लड कल्चर. इट विल टेल यू, क्योंकि उसमें नॉर्मल होगा या कम होगा. एंड आई थिंक दैट्स द वे टू गो. टाइफी डॉट सीरोलॉजिक टेस्ट इज वेरी डिस्करेज्ड बाय लॉट ऑफ research looking at the specificity, and Dr. Saab ne jo baat ki hai, and also not helpful in the diagnosis, because what you're doing is you're getting the result. Patients come, पिछले एक साल से मेरा टाइफाइड पॉजिटिव आ रहा है, डॉक्टर साहब इसको ठीक करें, and we have seen people being treated for that. दूसरा जो है अगर रिजल्ट ये अच्छा भी होता फिर भी शायद मैं यहाँ यूज करता, because with the resistant pattern that we are seeing, you want to have the cultural sensitivity data of the Salmonella or non-Salmonella paratyphoid. Because that you, as a clinician, I want to know that, given that we have to make a decision on the right choice of antibiotics. So, मेरे ख्याल में serologic test is discouraged. It is we have gone off it. We have not using it now in Shifa. We circulated a memo regarding that with references telling that please do not use it because it is not in any big ID books, at least in even microbiology books. So,
sir, especially in developing countries where it is endemic, it is not recommended, and I think there are references available for that.
Please, at your convenience, give me the reference where it is that it should not be used.
Sir.
The main problem is that typhoid kits which are in the market are not up to the standard. The standard typhoid kit are giving very good results. I agree that standard thing should be blood culture, but there are not blood culture facilities in our country in every, even I would say even up to district level sometimes. Maybe now it is available, but it is not at Tahsil level or sub-Tahsil level, or you can't get blood culture. Blood culture is all right, very good. Now the question is that Vidal test, which continued for years, the basic thing was the use of the antigen against Salmonella typhi and Paratyphi A and B. We don't do C because C is not here in Pakistan. And the serum versus that antigen in dilutions. In typhoid you are not doing any dilutions. Do it with dilutions and you will find much better results.
So,
Please let me complete and then you speak.
Okay.
Now, you have just mentioned a very big point which I have not seen, that if the developing countries should not use or whatever reference you are giving, that will be very interesting. Serological test as a whole, we always write down, this is not the final diagnosis. Any serology, I would go. You were talking about brucella and others, even they are not the real diagnostic tests. It is very difficult to grow brucella. And if we say, okay, we go for culture, for everything, that is not available in our country at small place. This is good in Rawalpindi, Lahore, Peshawar and everything. Hence, I would not discard typhoid, except that the typhoid kits are lying बोरियों में या डब्बों में या बोर बाजार में पड़ी हैं. This is the problem. Thank you. No.
Thank you, sir.
Thank you very much. Thank you, General Karamat, for your valuable comments. Since due to some time constraints, we'll take any other questions during the dinner. Before heading on to the business session, I would like to invite Dr. Muhammad H. Qazi, the Chief Executive Officer and today's chief guest, onto the stage for his address.
Bismillahirrahmanirrahim. Assalamu alaikum. Thank you very much for giving us the opportunity to share your knowledge and expertise with all of us. I especially would like to congratulate Dr. Imran Nazir and his team for hosting such a wonderful meeting. This is a special time for Shifa. 1993, 25 years ago, exactly 25 years ago, when we saw the first patient at Shifa International Hospital. We did the first CBC 25 years ago. Started as a small setup. 10 doctors, 20 beds, about 7 employees. And from that point, we have grown to more than 500 beds, more than 250 consultants, postgraduate trainees, more than 350, a prime tertiary care hospital of the country, well respected, accredited by Joint Commission and several other bodies which come and recognize the excellence nationally and internationally. Our laboratory at that time was just one room. We had one pathologist. He was our pathologist. He was a technician. He was a chief technician. He was supervisor. He was manager. Very fortunate that he's still present among us. Dr. Fazlai, thank you very much. We really appreciate that. Shifa Lab has come a long way since you started. He was very particular about teaching, training, quality control, very strict, very soft, very humble, very gentle, but never compromised on the quality. And I think those are the foundations which you laid, and that's why we got the Joint Commission, we got all of the respect wherever you can. Just like Dr. Fazlai had challenged at that time that there was no reliable technicians available, no reliable junior doctors available. We had the same challenge in all the other departments too at that time, 25 years ago. As a cardiologist, I was a nurse, I was the echo technician, I was the cath technician, I was the ECG technician. So we realized that that cannot go on for too long. So to make life easier, more efficient, more productive, more quality, we started the training programs of young doctors, technicians, nurses, and that has culminated now to the university, Shifa University. We have Shifa College of Medicine, we have Shifa College of Nursing, pharmacy, medical technician, and we feel very comfortable that now we have that manpower, that not just one Shifa, actually our manpower has made a positive impact on a lot of other hospitals and healthcare setups in Rawalpindi, Islamabad region and beyond. Just like in Karachi, Aga Khan has a positive impact on healthcare in Karachi. We feel very proud and comfortable that we have similar impact here also. Pathology department is our pride. They started with one room, but now looks like they've taken over the hospital, actually. Wherever you go, there's a pathology department, where there's a whole floor, operation theater, ER, ICU, even point of care testing. So our pathology department is present all over the hospital, and they're still looking to expand, and that's a good news. Actually, after Joint Commission, they are looking for PAP certification, which is the most someone can imagine. Actually, we never thought of that, Dr. Imran, before, but now, since such a quality is being delivered, we'll go for it, inshallah, and be successful on that. With quality comes the trust. And doctors from all over the northern region and Punjab, they send their most difficult cases to Shifa pathology. वो दूसरे पेशेंट तो नहीं भेजते, लेकिन जब उनकी फैमिली होती है तो ज़रूर कहते हैं जो शिफा में जाके कराना, वो ज़्यादा रिलायबल है. And that's fine with us. Our department is getting busier, whether it's a kidney transplant slides, whether it's a liver transplant or immunology, or you name it, and they'll say, okay, it's done from Shifa. Actually, our own competitors here, locally and others, they say, okay, you go to Shifa. And we trust their test. So they have earned their trust. And we feel that we can share that knowledge, that expertise with all the pathologists locally. Our laboratory, our doors, our hospitals are open for knowledge sharing, for expertise sharing. If you can come and help us improve our quality, we'll be glad. If we can help improve your laboratory, your hospital quality, we'll be more than delighted to work with you. So with that, again, I thank you very much, Dr. Imran and the team, and all of you for coming here. Thank you very much.
On behalf of Pakistan Association of Pathologists, I would like to thank Dr. Manzoor Kazi for taking out time from his busy routine and embracing today's event. Thank you very much, sir. And now I would like to invite Dr. Fazl Elahi onto the stage to please present a shield to today's chief guest, Dr. Manzoor Kazi. Sir, please come onto the stage for shield distribution. Thank you very much, sir. I request Dr. Lubna to please stay on the stage for shield distribution. Now I would like to invite Professor Dr. Suraya Wajahat Latif onto the stage to please present shield to Dr. Shavana Kamran for her very nice presentation in today's event. Thank you very much, ma'am. Now I would like to invite General Sohaib onto the stage to please present a shield to our next speaker, Dr. Muhammad Usman. Thank you very much, sir. Now I would request Professor Dr. Khalid Hassan onto the stage to please distribute shield to Dr. Huzanfar Abbas for his presentation on implementation of POCT system. Now I would request our worthy guest, General Karamat, onto the stage to please give away shield to Dr. Imran Nazir, the Chief Pathologist and Director Lab at Shifa International Hospital, for organizing today's meeting. Sir. With this, we move on to the next part of today's meeting, that is the business session. And I'll start the business session by reading the minutes of 75th PAP Local Chapter Meeting. The 75th PAP Local Chapter Meeting was held on 14th of October 2017 at Islamabad Medical and Dental College. The meeting was attended by a good number of eminent senior pathologists, consultant pathologists, junior pathologists, and residents and students. The meeting started with a recitation of Holy Quran, followed by a welcome address by Professor Dr. Saeed Alam from Islamabad Medical and Dental College. The academic session had a very two informative presentations. The first presentation was by Dr. Tehreem Asif on expression of progesterone receptors in different grades of meningioma. It was a very interesting presentation as she shared and highlighted her study and shared the good results with us as well. The second presentation was by Dr. Wajiha Majibeen, and she presented a pilot study for her PhD program on diabetes mellitus type 2 complications, association of oxidative stress, gene polymorphism. The presentations were followed by a question and answer session and many valued comments by the audience. Academic session was followed by the business session, in which minutes of 74th PAP meeting were presented for approval from the House. The announcement of different workshops and PAP meetings were also made. This was followed by an address by Professor Dr. Lubna Naseem, Coordinator PAP, local chapter, and a speech by the chief guest, Professor Dr. Syed Shoaib Shah. The meeting came to an end by the shield distribution to the speakers and vote of thanks by Professor Dr. Khalid Hassan, followed by address by the chief guest. I ask the House for approval of the minutes of 75th PAP local chapter meeting. Thank you, sir. There are a few announcements to be made. The PSH conference is going to start from tomorrow, that is 1st of March. And I'm sure it's going to be a very good and a great event with a lot of learning and research discussions as well. Another announcement is that 8th HCSP and 5th IAP meeting is going to be in April, and the tentative dates are 20th to 22nd of April, and 15th March is the last date for the submission of the abstracts. The details are available on the website, which is hcsp.iap. And this meeting is going to be attended by a lot of international speakers who are going to make very, hopefully very good presentations and talks, and all the histopathologists are requested, and we're looking forward to see all of you there at this conference. With this, we come to the end of the business session, and now I would like to invite Dr. Imran Nazir onto the stage for the vote of thanks.
Bismillahirrahmanirrahim. I hope all of us are now updated about POCT, cytogenetics, and antimicrobial resistance by now. This gives me a great pleasure to stand here on behalf of whole Department of Pathology, Shifa Hospital, to say thanks to all of you, especially the leadership of local chapter, PAP. You guys have done a wonderful job, and I'm sure due to your consistent efforts, probably we are the most efficient chapter of the country as far as PAP goes. So keep up the good work. Then all of you individually, thank you so much. You guys came on a weeknight, taking time out from your professional or personal commitments. We really appreciate that, because your presence definitely made this a successful event. And in the end, special thanks to Dr. Qazi, who is always very supportive of diagnostic services. He's been very, very supportive of all the expansions that Dr. Fazlai started, and we are trying to catch up with the demands of the hospital, of all the clinical fields. He especially has been very, very helpful in encouraging all the departments of our hospital to participate in educational activities, be it local or national. So thank you, sir. Thank you very much. And there is, in the end, one small announcement that Dr. General Suhaib is here. He has some, I think he has written a new book. He will just like to say a few words about that. But before that, as soon as he finishes, we'll get a group photo here before going for the dinner. And please, all of you should stay for the dinner. So, sir.
Bismillah ar-Rahman ar-Rahim. Thank you very much. I'm really grateful
especially Brigadier Tahir Aziz, for giving me this opportunity. Well, this is a small book. Well, it's about genetic hemoglobin disorders in Pakistan. We know several books have been written on this subject, but this is different because it gives you an outline of how we actually see it in this country. Thalassemia is a very common problem over here. Every year, approximately about 5,000 children with thalassemia major, they're born, and unfortunately, they're really mismanaged. Well, then there is a lot of information available that we can prevent this disease. And my lifetime experiences, they have actually been documented here. In fact, I do get, I think a day doesn't pass that I don't get a query about, Jana sahab, ye ek masla phas gaya, isme bataएं kya kar sakte hain. So I think the solution lies here. इंसान तो आनी जानी चीज़ है. आई होप कि जब मैं यहाँ नहीं होगा तो दिस बुक विल बी हियर, तो इंशाल्लाह ये काम आती रहेगी. और मेरी ख्वाहिश है कि ज़्यादा से ज़्यादा लोग इसको पढ़ें. मुझे किसी ने कहा कि आप इसको बिल्कुल फ्री डिस्ट्रीब्यूट करें, और मेरी ख्वाहिश है, बहरहाल नॉलेज है, सबके साथ शेयर होना चाहिए इसको. बट देयर इज़ अनदर स्कूल ऑफ थॉट. मैं एक ऑटिज़म सोसाइटी है जिसको रन करता हूँ इन सम कैपेसिटी. तो मेरी वाइफ मुझे सुबह कहती है कि तुम्हारा दिमाग ख़राब है, तुमने इतनी मेहनत से लिखी है, इससे तुम्हें पैसे लेने चाहिए, तुम हमें दे देना वो पैसे. मेरे दिमाग में बाकी बात आ गई कि ये बात तो सही कह रही है. ज़ाहिर इसमें से कितना आप कमा लेंगे, लेकिन ये कमाने के लिए नहीं है, ये दिस इज़ जस्ट फॉर शेयरिंग नॉलेज आई थिंक. और अगर इसमें से हमें कुछ इनकम मिल जाती है तो आई थिंक वी लाइक टू स्पेंड ऑन children with disabilities, not just autism. I think these children with disabilities, thalassemia in itself is a very big problem. डॉक्टर खालिद मुझसे पूछ रहे थे कि ये कहाँ से मिलेगी. अभी तो फ़िलहाल सारी किताबें मेरे पास हैं, मेरे कब्ज़े में, तो मुझे जो अप्रोच करेगा मैं उसको दूंगा. और बस इट्स एज सिंपल एज दैट. इफ़ यू हैव अ क्वेस्ट फॉर नॉलेज, यू कैन कॉन्टैक्ट मी. राइट. थैंक यू वेरी मच.